Complexities in Left Main by Dr. Anil Dhall from India. Can you join with us, sir? Slide.
Yeah, I will. Okay.
Okay, let me introduce Dr. Colonel Anil Dhall. He is the professor and head of the department, cardiology department, Janakpuri Super Specialty Hospital, Delhi. And it's our honor. He is an international speaker and he will talk on managing complexities in left main disease. I think our fellows will enjoy this session as well as we all learn something. Thank you very much, sir. Can you start your session?
No, the same session.
Can you see the slides now?
Sure, sir. Left main trifurcation.
Right. So I'm basically going to discuss a few cases of left main trifurcation. Left main bifurcation is bad, but evidently trifurcation makes things even worse. And really, there's a certain percentage of people who not only have trifurcation, but also have a significant quadrification and pentafication. So about 10% of all left mains can have trifurcations, which has therefore 3 branches, at least 4 different angles, and a wide variability in branch size and disease. There are many definitions, but we can usually define it as involvement of more than 50% within 5 millimeters from carina in these vessels. We have 3 major ways of defining it. As to classifying it, we can use the modified Medina classification. We can use a simple classification by Shamas, which classifies them into type A, type B, which is type B is involving the origin of the branches, but not the left main. And then there is a recent ABCD classification, which makes things a little more prognostically important. However, it becomes a little more tedious. So most of us continue to use the Medina classification. So, and if you look at it, we need to know whether the left main stem is diseased, whether one or all of the trifurcation vessels are diseased, and how badly is the carina involved. So this we can do by identifying the main and side branches. We can look at the various angles, but there is a little discussion on the B prime angle, which is the angle between the main branch, which is usually the LAD, unless the LAD is type 1, and an imaginary line which continues in the direction of the left main. We also understand that the problem of having 3 or 4 branches to address simultaneously is that we are creating a lot of shear stress, especially with stent implantation. And also, we may be able to distort a lot of these stents. So we need to have an optimal stent expansion, and we need to judiciously use proximal optimization and a better technique, preferably under image guidance, to achieve better outcome. Well, we can all say that surgery becomes a very easy choice, but we can clinically risk stratify by using various clinical scores. We can look carefully at lesion morphology, calcification, tortuosity, and the side branch pattern. Because when the trifurcation carina is severely diseased, and it is a disease involving all the ostia, it becomes even more difficult when the angles are narrow. And during the performance of the PCI, the angles of the left main tend to change. And this can, if it is more than 11 degrees, can actually impact the outcome, because you will not do as well as it has been planned. And the size, because can you ignore one vessel, or do you have to consider all 3, which is important? Very clearly, you need a large bore guiding, and it would be judicious to start with a 7 or an 8 French guide catheter. Almost all the bifurcation techniques can be judiciously used, but you need to protect all 3 branches if they are more than 2 millimeters with a reasonable perfusion territory with a wire. And you need to also treat the side branches if you think that there is a significant plaque shift, and if it is going to involve a certain percentage of the myocardium at risk. Well, just like we have kissing, and kissing is of significance, we triple kiss or a ménage à trois has been called as trissing, and this can be either done sequentially. But if you have metal in all three vessels, then even by doing a kissing may not be enough. And you may actually need to do trissing to avoid a major oval distortion. And you may need to have a repeated proximal optimization to restore fractal geometry. And you may need to use 3 balloons simultaneously. And this may influence the access site which we may choose. So let's go through a few quick cases because the time is limited. I start with a simple trifurcation. 70 male, hypertensive, non-diabetic, chronic coronary syndrome, dominant circumflex. Now, don't forget this. Dominant circumflex with a large ramus. And here is involvement of all 3 ostia. So it can be considered 0, 1, 1, 1, or a Shama's A, which is, or an ABCD A, which is involved here. Now, what do we do? What do we plan? Now, this patient, obviously, an easy outcome would be to plan a surgical revascularization, but the distal targets are so good. So you are also tempted that, hey, let me see if I can address this by a percutaneous procedure. And then the family perks up and the patient perks up and says, I want an interventional procedure. So you can offer intervention. You look carefully in certain angles, you'll also find distal left main disease. So it is not just 0, 1, 1, 1, but it is actually 1, 1, 1, 1 in this. So you use an 8 French, we used an 8 French guiding, wired all three branches and proceeded to pre-dilate. Now, we had done a quick intravascular ultrasound and found that there is not much calcium burden. So I did not have those images. So we went ahead and dilated all the 3 vessels in the ostia, and then made it very simple. Started with a left main to LAD stent. The stent was sized by the distal vessel, which was 3.5 millimeter in diameter. We took 38 millimeter stent. This is an everolimus eluting stent. We made sure that we had adequate length of the stent in the distal left main so that we could do a pot. And we went ahead and post-dilated. First, we deployed this stent and then post-dilated this stent with a non-compliant balloon, and further went ahead with a small non-compliant balloon of the distal left main, went ahead and did a proximal optimization. This allowed us better access to recross the jailed wires, the jailed vessels, and the jailed wires were removed. Then we opened the left main to LAD struts to both the ramus and the circumflex. And with this, we went ahead and after opening the struts in the circumflex, we did a pre-triss. So we actually did a trissing balloon even before putting the other 2 stents. And then we went ahead and placed 2 stents, one a 3 into 20 in the circumflex and 2.5 into 20 in the ramus. And this was like a double tap with simultaneous inflation of both the ramus and circumflex stent with a balloon in the LAD. And this is the angiogram post-tap. We further optimized this with non-compliant balloon, checked the results on imaging, and this was the final result. So with making the condition simple, we could treat a trifurcation by doing a double tap with the first main stent being placed from LAD to left main. The second case is a little more complex. There's a little more calcium here. We had to, and the angles were a little narrower with significant disease, again, being in the proximal LAD and in the ramus and in the circumflex. Here we also realized that we may have to protect the septals, and I kind of like to protect the septals, pre-dilated and then finally stented the left main to LAD, and then did a kissing inflation towards the left main, and then also a simultaneous tris. And after this, we again checked our circumflex and ramus, and we did actually an IVUS and found they were both significant. And we also did an intravascular ultrasound and found that they were both significant. So again, we used a T stenting towards the circumflex and intermediate with a 4 millimeter balloon inflated in the LAD. And so we kind of created a situation like the first case with a single balloon left main to LAD and two balloons in ramus and circumflex. And then we finished with non-compliant balloons and finished with a tris and checked the results on intravascular ultrasound. We needed further optimization, and we had this patient has had good follow-up. But everything is not always hunky-dory. So let me tell you some disastrous stories of what could happen. And this is everyday life. Here is a patient who came to us with an inferior myocardial infarction. A quick angiogram revealed that there was disease in the LAD, there was disease in the circumflex, there was disease in the ostium of the ramus, but the operator could not clearly identify the ramus origin, and he went ahead and treated, because this was a right coronary artery which was totally occluded. So went ahead and performed a primary PTCA to RCA with a reasonable result. Now, when the patient was offered that he needs treatment of his left system, he came back, he said, I still want a PCI. So we did a staged PCI, and this was a 7 French EBU with the right femoral axis. The primary was done through a radial axis. Now we came back because we knew we needed large bore. We treated the LAD in a standard method, and it was stented, optimized with a good final result. We thought the ramus was going to be very easy. So I let my colleague went ahead and placed pre-dilated the ramus, and then we got a little ambitious because we thought that, okay, we can do a precise placement at the ostium of the ramus. And this was something which was probably in hindsight may have been the key to this case, because we went ahead, stented this, but I was called in when, after doing this, he was unable to deliver a balloon to the distal circumflex. Well, first things first, I said, okay, your stent has come into the proximal circumflex. Let's rewire it. We rewired it, and we took another balloon. But this time we could actually deliver the balloon, but we found it very difficult to deliver the stent. So we had to again pre-dilate the ostium of the circumflex to allow the stent to go in, because if you recollect, we had distal circumflex disease. And for optimization, we ended up doing a kissing inflation between circumflex and ramus. And then we went ahead and directly stented the distal circumflex. But by now, the circ ostium looked a little hazy and pinched, and we did not have intravascular ultrasound available in that lab on that day. So initially we thought we'll do a precise placement, but later we knew we were using a 3.5 millimeter stent. So we could pull the stent back into the left main, and we decided that we will crush the ramus stent, because it had come into the proximal circumflex, and this was the circumflex to left main, which was stented. Now, despite a pot with a 4 millimeter balloon and adequately expanding the left main, we could not recross into the ramus. Now, this should have rung a bell into our minds, but we realized that a lot of time had already elapsed. The patient was a little uncomfortable because of a fair amount of effort being spent in rewiring. So we actually accepted this final result. It all appeared to be flowing very well. And we said, all right, we will keep this patient on follow-up. All three vessels appear to be flowing well. You can see the distal left main appears to be dilated well. The proximal circumflex, the proximal ramus, the distal circumflex, and the LAD all appears to be doing well. Well, this patient went home and was prescribed aspirin ticagrelor and was called for review a week later. But 10 minutes before his appointment, he said he's feeling unwell. The first ECG was okay, but he was getting sweaty and clammy. And then he told us that his medicines come from his panel, and that panel had not yet supplied him the medicines. So he had not taken antiplatelets after he left the hospital. And when we took him up immediately with a suspicion of stent thrombosis, and what do we find? We can't see the ramus. We find that there is a clot in the distal left main. There is a clot in the ostium of the LAD. And by this time, we had started with the 7 French EBU 3.5 guide with a femoral access. Well, immediately all hell was raised. We knew where the ramus was. I quickly came and tried to wire this occluded ramus. We put in multiple wires into the circumflex and into the LAD, did a couple of thrombus extractions, which was not possible. So then we did a step balloon with 1.5, 2.0, and 2.5, got some flow into the vessel. Some clot appeared to go down the LAD, and LAD appeared a little hazy. So now we had restored flow by this time in all vessels. But then the option of CABG was also discussed with the CT surgeons, but they felt it was too high risk because now the patient was with abciximab and other things. So we went ahead, we thought we'll complete the procedure. There was already a stent, as you recollect, which had crushed the ramus stent, which was there from left main to circumflex. So we did a tap to the LAD, the ostium of the LAD, and then we did a kissing. Now, the first kissing was possible with a kiss in ramus. We did the tap to LAD, and then we again did a kissing between the ramus and the circumflex. But we wanted to do a trissing. And despite whatever we could do, despite the 7 French guide, we could not take 3 balloons. So we were really stuck. We thought, should we now change to an 8 French guide, which may be a default option here? But we thought, no, we have another groin. We took another axis, took another 6 French guide, and used a ping pong guide. So we took access with another guide, and with that we could have 2 guides, and we could deliver all 3 balloons, and we performed a trissing, and by which time, of course, our confidence grew, and by this technique we could have a satisfactory result. We went ahead and placed we went ahead and did imaging in all the 3 vessels, because we did not want this to ever be repeated, because now this patient has had a follow-up for over 2 years, and he still calls me on all the festivals, which to tell me that he's doing fine, and he comes and sees me once in 6 months. So not doing final kissing in circ and ramus is an issue, but we must remember the likely site of thrombus in the triangle of death can be a real problem. Of course, the non-compliance is a major problem, and you have to be very, very careful. And this is after we had spent time with him and his family, telling them about DAPT, but it yet didn't happen. So there's many a slip between the cup and the lip, and we ensured final trissing by using a double guide or a pinpoint guide technique. Now, the last case which I want to discuss is actually something which can happen to anybody. And here's this patient who we knew had a pacemaker, but we did not know what kind of pacemaker. And this ECG, I put it here because my fellow picked up this ST elevation despite the pacemaker. The moment we took him on the table, we realized that this is a guy who's got a CRTD, and his antecedent ejection fraction was 15%. So we figured that he had an LV clot which had embolized. And that's what we found. This is an LV clot which had embolized into the left main. It is said that they more often embolize into the right coronary artery because of the anatomical location. But here was a left main, and we did not know the anatomy. So we first wired the LAD and circumflex, because everybody knows that LAD and circumflex exist. Then we went ahead and did multiple thrombus aspiration. We used our own homemade cocktail of lytics and glycoprotein 2B3A inhibitors, restored some flow. First, we started seeing some flow in the LAD. Then we continued the same in the circumflex. We saw some flow in the circumflex. And by which time we realized, oh, this is a trifurcation. So it should not surprise us, because like I said, in a certain percentage, you are going to have trifurcation. And this may vary from population to population, but it is there. There was a significantly sized ramus. So we went ahead and completed. We removed this clot. There was obviously not much atherosclerotic burden because this was all embolic. And we finished with this flow. But the LV was badly stunned. And you can see that we've got an excellent TB3 flow. We've got good blush as well. But the pressures were very low. He was in profound cardiogenic shock. His lactates were through the roof. And the ejection fraction on the echo was still less than about 10%. He did not, we offered him an ECMO, but he did not have the financial capability or the wherewithal, and the family knew the outcome that was possible. So we put in a balloon pump, but unfortunately, and when we did an echo, we reconfirmed the LV thrombus. But despite that, we could not salvage this patient. So I've shown you a spectrum. We must understand that we need to protect all three branches because all three branches are proximal vessels. They would subtend a large myocardium. We need to be able to treat them and respect whatever metal we place in them by doing an optimal stent expansion with optimal sizing. We decrease the malapposition, preferably with imaging and physiology. There may not be consensus regarding regarding circulatory support, but if there is an LV dysfunction or an occluded RCA, I would not hesitate. I would again repeat that we have to be very diligent about antithrombotics and DFPT. Now, left main trifurcation angioplasty is challenging as the anatomical patterns may be variable. There is a potential for procedural complications. There is no defined standard approach. But whatever you may do, all that you must see is, regardless of the technique used, you must finish with imaging and at least with the satisfaction that you have opened and opposed every bit of stent to the wall. You have got no residual stenosis and no residual thrombus, and that this patient is compliant with his dual antiplatelet strategy. Thank you very much. I do hope I have finished in time.
Thank you, Dr. Anil Dhall. I am Professor S. Mustafa Jaman.
Hello, Mustafa. How are you?
I am nostalgic again. I meet you again, and before COVID, just we meet CTO.
That's correct.
No, and that summit.
We are proud of you.
Presentation by you, actually, lot of technique and tricks already I have seen, and our fellows will be learned many things today, I think. And my question to you, your first case, you have shown the tracing balloon, and especially, already you have mentioned that the triangle of death. So triangle of death, and already your placement of stent and balloon at that place. So our fellows actually, we want to know the tips and tricks at the junction, where the placement of the stent and balloon in case of that moment.
So optimize very well. The only lesson I would like to leave for others, for my younger colleagues, is must ensure that you spend adequate time in optimizing your results and make sure that there is no distortion of any metal material. I have done left main trifurcations with using one drug-eluting balloon in the ramus with a ramus so small, and they've also held out with reasonable results. But by and large, I'd like to minimize the metal. If I choose the metal, then it has to be a validated, good quality stent with preferably with thin struts and with very effective dual antiplatelet, but image guided, so that we can have excellent apposition. If you can also check with physiology, if you have the time. Two of these cases were in STEMI, so we did not really have the time. But if you have the time, I like to ensure that the physiology is perfect, the anatomy is perfect, and whatever technique you may use, you remember, size the stent by the distal vessel and oppose the proximal well to the left main wall. And believe me, people keep talking about smaller left mains in India. I have not seen left mains less than 4.5 or 5 even in our country. So if you do regular imaging, you would use an appropriately sized balloon. Sometimes there becomes a challenge. In many labs, you don't have short 4.5 and 5 balloons, and this can be a real challenge, but which we need to overcome by talking to our managements and the lab managers and ensuring adequate supply of these short balloons, especially to do proximal optimization. I cannot, once again, underscore the importance of doing proximal optimization. It allows you access to the distal vessel. I once again tell you that we go step by step. We open the struts of the distal vessel. Don't be in a haste. Haste makes waste. Go methodically each step, and you will have durable long-term results. The first case is now about 5 years of follow-up, and he's doing fine.
Thank you, Dr. Anil Dhall. Are you hearing me?
Yes, sir.
Thank you, Dr. Anil Dhall. I am Professor Mir Jamal, Secretary General of Bangladesh Society of Cardiovascular Intervention and Director, National Institute of Cardiovascular Diseases. I have seen all of your cases. These are the case of master of masters. And really you are master and you have mastering your cases and we have enjoyed much. But I have to know something from you. Number one, in case of trifurcation, all the cases you have done LM to LED first and then two stands. One is LCX and another is Ramus. Whether you have entered in two different starts into the LCX and Ramus intermediates, definitely you have entered in LCX.
You know, that is why I did a pre-tris. So to determine that, you've done a pre-tris. Now you know the expansion capabilities of most of your stents.
Yes.
And by doing a pre-tris, which is not really a recommended step, what happens is that you become comfortable that you'll be able to deliver the stents. Because once you've taken a stent, you should not be having the difficulty that you have taken both the stents through one strut. And we are frequently using a lot of imaging. Now we use OCT to actually determine which strut we have used to enter the vessel. So we are very clear that these are not the same strut, but different struts.
Yes, that different strut. One. Second one, you have kept the balloon in the left main inflated to prevent the stent to come into the LM and to keep, stay the stent into the ostium of the OM and SIR.
Yes, in a way you can say that is correct. But it also serves because eventually we have to do a kissing or a trissing. So this serves as a background for doing the next step and allows me continuous access. Remember one thing, left main to LED remains left main to LED. And you need to protect that at all costs and never jeopardize.
No. My question is that whether this side vessel two stents, initial struts of these two stents is inside the left main or into the ostium of the SARC and ramus.
No, this is into the ostium of the SIRC and ramus. You can never be perfect. You cannot ensure that it doesn't come.
Right,
and even if that happens, it will lead to an internal crush. We tend to minimize that by looking in several views and trying to open the struts well before we place these stents.
Okay,
Okay,
so
thank
far
you.
I can get your point. Actually, no one interventional cardiologist can make sure whether he should enter the one or two stent through the stent start. So, okay, wonderful talk, Professor Anil Dhall. We learned a lot from your talk, and it's my honor and privilege to introduce our president, Professor Akam Fazlur Rahman. He is the president of Bangladesh Society of Cardiovascular Intervention. He is the chairman of Bangladesh Bangabandhu Sheikh Mujib Medical University, as well as next door, he is the Professor Mustafa Jaman. He is also working Bangabandhu Sheikh Mujib Medical University. Then next, our Professor Mir Jamaluddin. He is also Secretary General of Bangladesh Cardiovascular Intervention. Me, Scientific Secretary of Bangladesh Society of Cardiovascular Intervention, now working in NICVD. Thank you.